Good evening, everyone, and thank you for joining us. We're thrilled to welcome you to tonight's Ontario-wide accredited education series on lower limb preservation and treatment strategies. This session is eligible for up to 2 CME or CPD credits for physicians, and we're looking forward to sharing practical tools, clinical insights, and strategies you can take back to your practice. Please note that this session is being recorded and will be made available to participants afterwards. We're looking forward to an engaging and informative session. So please feel free to type your questions into the chat box at any time. Our team will be monitoring it throughout and we'll be happy to respond. We'll also have a dedicated Q&A session towards the end. We know how valuable your time is, and we're grateful to have such a dedicated group here committed to enhancing patient care. Before we dive in, I wanted to extend a big thank you to everyone for their generous support in making this session possible. Thank you to our education leads, the Windsor Family Health Team in collaboration with Windsor Regional Hospital and the Windsor Essex Ontario Health Team. This partnership has been instrumental in allowing us to bring this learning opportunity to our healthcare community across Ontario. Next slide, please. We would also like to sincerely acknowledge the Windsor Essex Community Health Center, the Windsor Essex County branch of Canadian Mental Health Association, Ontario Health, and the City of Windsor for their valued support and collaboration in advancing the Lower Limb Preservation Strategy Initiative. Next slide, please. I'd like to begin today by offering a land acknowledgement. We respectfully acknowledge that the land we are presented on is a traditional territory of the Peoria, Wyandotte, Mississauga, Mi'kmaq, Anishinaabe, Attiwandarok peoples. Indigenous peoples have cared for these lands for generations. We honored their deep connection to the land, the water, and all living things, recognizing their ongoing presence and invaluable contributions. We are committed to truth, reconciliation, equity, and to fostering respectful relationships that support healing and justice. Thank you. Next, please. All right, so welcome everyone. We're going to start off with a quick poll that should pop up on your screen in just a moment. The first poll has 2 short questions. It's what health profession do you represent and where you are joining us from today? We ask this because we value the diversity of roles and voices in our healthcare community. Whether you're primary care, mental health, social services, or community outreach, your perspective matters. This helps us reflect on who took part in today's session and ensures that our collaborative efforts continue to represent the full spectrum of care providers supporting lower limb health.
I do apologize. There was a technical glitch with that particular poll, so we'll have to skip past that, Harrison. That's my fault. I apologize for that.
No worries. For those that were able to participate, we do appreciate you for participating. It's from the polls that we were able to see. It's wonderful to see such a diverse group here today. We got folks joining from Windsor Essex and beyond, and a great mix of professionals as well, from primary care providers to community health and social services. So welcome everyone. Next note, please. It's now my pleasure to introduce our speakers today. So before we begin, please note that none of our speakers have any direct relationship with financial sponsors to disclose. We don't have any direct financial relationships or honorarium, no patents for drugs or devices, and no financial investments or other conflicts of interest. I'd now like to introduce Dr. Maher Sabalbal, vascular surgeon at Windsor Vascular Care and Windsor Regional Hospital. Dr. Sabalbal will be sharing his vascular insights with us and will be presenting our 3rd clinical case of the evening, which focuses on peripheral arterial disease. We're so grateful to have him with us tonight, sharing his plethora of experience and expertise. Welcome, Doctor.
Thank you very much.
Our next speaker is someone deeply involved in lower limb wound education across our region. I'm pleased to introduce Dr. John R. Coates, family physician at Windsor Family Health Team and adjacent professor in the Department of Family Medicine at the School of Medicine, Western University. Dr. Coates also serves as a primary care consultant to the Windsor Essex Ontario Health Team's lower limb preservation strategy, bringing invaluable frontline insight and leadership to this important initiative. We're excited to have him with us today to share his expertise and help guide our clinical discussions. Welcome, Dr. Coates.
Thanks.
I would also like to introduce Dr. Lyndsay Orr, who brings an important system-level perspective into today's discussion. Dr. Orr holds a PhD, a Master's of Clinical Science in Physical Therapy, and currently serves as a lead of integrated care at Ontario Health. She is also an assistant professor at Western University, where she contributes to advancing health system leadership and interdisciplinary care. We're grateful to have Dr. Orr here to share her insights into integrated care models and how they align with the goals of the lower limb preservation strategy. Welcome, Dr. Orr. Our next speaker is a dedicated frontline provider and a familiar face to many in this presentation. I'm pleased to introduce Harleen Sanghera, who holds a Bachelor of Science in Nursing, a Master's of Nursing, and is a nurse practitioner in primary healthcare. Harleen serves as a nurse practitioner at the Windsor Team Care Center, as well as the Windsor Lower Limb Wound Prevention and Treatment Clinic, where she plays a key role in providing comprehensive wound care and patient-centered support. We're excited to have her today to share her clinical insights and real-world experience with lower limb preservation. Welcome, Harleen. Our next speaker, Christine Abraham, is a dynamic leader and passionate advocate for integrated community-based care. Christine holds a Six Sigma Black Belt professional designation and an MBA in health system leadership. She serves as the lower limb clinical coordinator at the Windsor Lower Limb Wound Prevention and Treatment Clinic, and as the special projects coordinator at the Windsor Family Health Team. Christine also is the application manager for tonight's accredited education program on lower limb wound prevention and treatment strategies, helping lead to design and coordination and continuing education accreditation process. Christen's leadership brings together clinical excellence and strategic innovation, helping ensure this initiative delivers meaningful, sustainable impact for patients and providers alike. Welcome, Christen. Finally, my name is Harrison Tolko, and I'll be the MC for today's session. I'm the Operations Manager for Allied Health Services at Windsor Regional Hospital and a proud member of the Windsor Essex Ontario Health Team's lower limb preservation strategy. In my role, I've had the opportunity to support cross-sector collaboration and help drive the operational side of the important work, bringing together clinical teams, community partners, and system leaders to make meaningful patient-centered care a reality. I'm really excited to guide us through today's session, and I look forward to everything we'll be learning and sharing together. We want to acknowledge that the facilitators are fully responsible for developing the content of this learning activity. Every effort has been made to ensure scientific integrity and balance throughout. Our speakers are experienced medical and allied health professionals who work directly or indirectly with patients experiencing lower limb wounds, particularly those from vulnerable populations, including people with chronic conditions, diabetes, or those experiencing homelessness. Some of our speakers also bring lived experience and deep involvement in interdisciplinary care, and each has a minimum level of experience delivering education in Ontario. Next slide, please. We'd like to discuss that Dr. Coates previously received an honorarium for participating in one advisory board consultant meeting with pharmaceutical company. This program has been developed by the Windsor Family Health Team in collaboration with Windsor Regional Hospital and the Windsor Essex Ontario Health Team. There's been no financial or in-kind support from any external sponsors. So here's a quick look of what we'll be covering tonight. We'll start with a brief pre-session assessment and introduction, followed by an overview of the importance of lower limb health and our current pathway. From there, we'll dive into our care-based education, where we'll explore key lower limb conditions, basic tools and assessments, and how to support transient or hard-to-reach client populations. Dr. Coates will be walking us through two important clinical cases, a diabetic foot ulcer and a venous ulcer, and we'll close that section by discussing the broader care continuum and how this fits to your day-to-day practice. After that, we'll move into an advanced case education and vascular insight portion of the evening. We'll explore advanced clinical scenarios and hear from Dr. Sabalbal as he presents our case 3, focusing on PAD and key contributions from a vascular surgery perspective. Then to wrap up, we'll review the care pathway and highlight some Ontario-specific resources and tools that you can take back to your teams. And then we'll share some details on how you can claim your CME, CPD, and certification of attendance for credits. Next slide, please. So our key objectives for today are to give an overview of the current state of lower limb amputation in Ontario, to introduce the lower limb preservation strategy, to provide clinical education on chronic conditions and lower limb health, to demonstrate best practices using tools like the in-low 60-second foot screen and the PWAT, and to share practical tips, insights, and resources to support your care and enhance your practice. So before we dive into the content, we're going to begin with a pre-assessment evaluation. This is meant to help measure where you truly feel you are at your current knowledge of lower limb preservation. So we'll try again to do a poll, and if you could please answer as honestly as you can. It isn't a test. It's more so just to give us familiarize ourselves with everyone's knowledge. At the end of the session, you'll be asked to complete a post-assessment evaluation after you've had a chance to engage with not only the content, but also our clinical cases. Next slide, please. All right, to kick off tonight's session, I'm pleased to introduce our first speaker, Christen Abraham. She'll be starting us off with an overview of our lower limb preservation, focusing on the prevalence of chronic disease and its impact on limb health. Welcome.
Thank you, Harrison, and thank you all for being here tonight. Before I jump in, I just want to say how excited we are to be part of this important conversation. Lower limb preservation is not just about wound care. It's also about addressing the broader health system challenges tied to chronic disease, equity, and access. So with that in mind, let's start by looking at the prevalence of chronic disease and how it intersects with limb health and risk. Next slide, please. Let's start with a powerful statistic that really sets the tone for why we are here tonight. Every 20 seconds worldwide, a limb is lost to diabetes. And 85% of those amputations are caused by diabetic foot ulcers, which are often preventable with earlier screening, timely care, and proper wound management. In Ontario, we have 1.7 million people living with diagnosed diabetes. That's 11% of our population, or about 1 in every 9 people. And we know the real number is likely even higher than we account for undiagnosed or pre-diabetic individuals. Now here's the part that always stays with me. 1 in 4 people with diabetes will develop a foot ulcer in their lifetime. That's 25%. And it's not always due to something dramatic. It could be caused by neuropathy that dulls pain sensation, by deformities that create pressure points, or even just minor trauma, like a small cut or blister that goes unnoticed. These ulcers are often silent until they become serious. And once someone has a diabetic foot ulcer, the risk of amputation jumps to 20%. So 1 in 5 of those patients may lose part of their foot or leg. That is a huge life-changing outcome, and most importantly, it's one that we can prevent with the right tools and approach, which we will talk about tonight. Another critical piece to be aware of is peripheral arterial disease, or PAD. It is present in about 20% of adults over the age of 70, and many don't even know that they have it. PAD narrows the arteries and reduces blood flow to the legs and feet, which slows healing or prevents it altogether. And when you combine PAD with diabetes, the risk of infection and amputation increases dramatically. These numbers that you see here aren't just statistics. They represent real people we see in our clinics, in shelters, in long-term care, and in primary care settings every day. And they're exactly why lower limb preservation efforts are so essential. When we narrow the lens to Ontario, the numbers become even more urgent. Right now, there are over 310,000 people living with both diabetes mellitus and PAD who are at risk for losing a limb. That is a huge portion of our population, and the numbers of amputations continues to rise. Currently, we're seeing about 20,000 amputations every year in Ontario, and of those, 1,200 are major amputations, meaning above the ankle. To put that into perspective, that's one major amputation every 7 hours in our province alone. The financial impact is staggering too. Each major amputation costs around $70,000, and Ontario spends an estimated of $140 million annually on indirect amputation-related healthcare costs. And that does not even account for the human cost, the loss of independence, quality of life, or the emotional toll on patients and families. For someone with neuropathic diabetic foot ulcers, the 5-year mortality rate approaches 50%. And for those who undergo a major amputation, the outlook becomes even more serious. 80% will pass away within 5 years. To put that in perspective, that is a mortality rate higher than many cancers. That shows how vulnerable these patients are. Major amputations are often the final outcome of years of unmanaged or underrecognized chronic conditions like diabetes, PAD, or just delayed access to care. And when someone loses a limb, they aren't just faced with physical rehabilitation, they often experience profound psychological, social, and economic consequences. Depression, isolation, reduced mobility, loss of independence, and increased reliance on long-term care are all common realities. So when we talk about prevention tonight, we're not just talking about saving limbs, we're talking about saving lives and preserving quality of life. When talking about amputations, it's easy to focus on the clinical side naturally as clinicians, but the human side is just as important to recognize. Amputation has a devastating impact not just on the individual, but also on their entire family and support system. It creates an enormous emotional, physical, and financial toll, while also placing a heavy burden on our healthcare system. One of our biggest challenges is the loss of mobility and independence, which can make returning home or reintegrating into daily life extremely difficult. That is even more likely when the individual is managing other comorbidities like diabetes, PAD, or cardiovascular disease. We also see a sharp decline in functional status, increased rates of depression and anxiety, and the potential loss of employment, all of which contribute to reduced quality of life. And at the root of many of these cases are diabetic foot ulcers, a complication that's both serious and costly, but it's also preventable. Amputation is a real life altering event that leads to long-term physical, psychological, and social consequences, resulting in profound and measurable decline in quality of life. This graph here shows long-term survival rates following a major lower extremity amputation. And as you can see, this data is concerning. Survival rates drop sharply in the first few years and continues to decline over time. By year 5, survival rates fall below 50%, and by year 10, it's closer to 30%. What's even more concerning is the disparity in the outcome. The blue line represents the First Nations people, and the red line shows other people in Ontario who do not identify as First Nations. Across the entire timeline, First Nation individuals consistently have worse survival outcomes. This shows how compounded impact of systemic inequities, limited access to timely care, and broader social determinants of health are incredibly important. So while amputation itself isn't already life-altering, this graph shows us that post-amputation survival is an urgent equity issue that must be addressed in parallel with our prevention efforts. This slide represents one of our most important messages tonight, and that is amputations are largely preventable. In fact, 85% of amputations related to type 2 diabetes and PAD can be avoided with treatments and tools we already have access to. These include regular foot screenings, patient education on foot care and footwear, and a collaborative interprofessional approach to managing chronic disease, ensuring patients have adequate perfusion, infection control, and proper pressure offloading. But despite that, here in Canada, about half of people with diabetes receive appropriate foot screening. Even fewer are risk stratified, meaning many at-risk patients are simply falling through the cracks. And here's the financial reality. These preventative efforts cost 10 to 40 times less than hospitalizations and surgeries for amputation. If we reduce amputations by just 20%, we could save 240 lower limbs and cut costs by $16.8 million. That's a major win for both the patient and the system alike. And with that, I'll pass it back to Harrison, who will introduce our next speaker.
Thank you so much, Christen, for that insightful overview of impact of lower limb conditions in Ontario. It's a powerful reminder of why this work matters and how prevention and early intervention can truly save lives. I'm now pleased to welcome our next speaker, Dr. Lyndsay Orr, joining us tonight from Ontario Health. Dr. Orr brings extensive experience in health system design and integrated care, and we're excited to have her share her expertise with us this evening. Welcome, Dr. Orr.
Thanks, Harrison, and hi, everyone. I've had the great pleasure of working with the Windsor Essex OHT and team for the past few years as part of the Ontario Health Lower Limb Preservation Integrated Clinical Pathway projects. And so what is an integrated clinical pathway, or ICPs, as we like to call them? So they are coordinated cross-sectoral care plans that outline the evidence-based steps to improve outcomes for patients. So this work has been led by our OHTs with close collaboration and multiple partners, from acute hospital-based care to primary and community-based care. So teams like Windsor have led the way in driving change for integrated care delivery, specifically for lower limb preservation. Next slide, please. So why lower limb preservation? Well, Ontario's high and rising rates of lower limb amputation and a lot of the statistics that Christen just took us through, I don't think we need many more reasons to address this as an urgent issue for patients across the world, but specifically in Ontario. And that's what was shown in some research that was done, led by Legacy Core Health, which is now a part of Ontario Health. And what you're looking at here on the left is a figure of the previous legacy LHINs. So there was 14 LHIN regions, as you may recall. And what we can see is that the rates with closer to the center of Ontario, so more in the Toronto regions, are in the green. They're not as high of a rate in this area, but as we spread out towards the more rural areas and away from the Toronto, and especially into the northern parts of Ontario, we really see an increase in those rates. And when you look at that dark orange color in the Northwest and the Northeast regions, what you're looking at there is rates that are 2 times higher the Ontario average and 4 times higher the rates in the regions with some of the lowest amputation rates. And we also know that, as Christen mentioned, that for our Indigenous populations, rates of amputations can be up to 7 times that of the Ontario average, with a lot of our Indigenous communities being in those northern regions. So on the left, we're more comparing ourselves to ourselves in Ontario. On the right there, what you're looking at is comparing Ontario rates to other jurisdictions across the world that also have access to publicly funded healthcare. And so you can see Ontario on average perhaps isn't doing too bad, but when we take those minimum and maximum ranges, which are those yellow dots that you're seeing in the Ontario column there, you can see that some of our higher regions are even higher than other countries that are comparable to Canada. So we definitely have work that can be done in this space. Next slide, please. So because of this data that was uncovered, and again, all the stats that Christen listed for us earlier, Core Health focused on having a team lead the development of a framework that we could have here in Ontario for lower limb preservation. So an advisory committee was experts from all over Ontario and in all sectors across multiple professions came together, and they created a coordinated approach to deliver lower limb preservation care in Ontario. And the goal of the framework was to improve the outcomes for patients at highest risk for limb amputation, reduce avoidable non-traumatic major lower limb amputations, and to improve equitable patient access to those best practices outlined within the framework. Next slide, please. So as part of this framework, a model of care was outlined that included primary care. It also includes specialized wound care and acute lower limb care. So sometimes we refer to this as like a hub spoke node model, with primary and community care being the spokes, our specialized wound clinics being more of a hub, and the acute limb vascular care being the node. So this allows for patients to be escalated so that that risk assessment that Christen also referred to, we can then stratify patients to make sure that they are receiving the appropriate level of care at the right time, and that patients can also escalate and de-escalate their level of care as their condition progresses. 3 priorities for action were also identified, being that we want to prioritize integrated, connective, collaborative care. Just for the reasons we just talked about, we need to be able to communicate to have those transitions between the hub nodes and spokes. And we need to be able to communicate when we're in trouble as well, and escalate that care as quickly as possible. We also asked for teams to focus on early identification and preventative management, as well as coordinated and consistent wound management. Next slide, please. So at similar timing as this lower limb preservation framework was being finalized and communicated out to healthcare providers, an opportunity came up from the Ministry of Health to work with OHTs to begin implementing the LLP framework and ICPs. So OHTs, they were introduced in 2019 as a way to deliver integrated care across the province. They use a population health management model that's data-driven, and this is the same approach that Windsor Essex OHT and the lower limb preservation team use to focus on some of the most marginalized patients within their OHT. Next slide, please. So, oh, sorry, my slide's a little off there. So with the lower limb preservation framework as the evidence-informed guideline and the OHTs for the delivery of integrated care, the lower limb preservation ICP projects were initiated. And the teams that were involved, we called them demonstration programs at the outset, and they were asked to identify, prioritize, implement, and measure the impact of lower limb preservation change initiatives. So Ontario Health was able to provide some support and knowledge transfer and in regular touch points, also through a community of practice that everyone is welcome to join on this call. Reduce any barriers and help with evaluation of those programs. Our Ontario Health regions are also really key enablers for that implementation at a local level. And the lessons learned that we learned from these lower limb preservation ICPs are being used to drive system level changes to remove barriers for integration and improve access to care for patients at risk of lower limb amputation. Next slide, please. So these are the demonstration programs that we started with in October 2023, minus one that was added a little later in Niagara, but everyone has been participating full force at this point in the lower limb preservation projects. So it's been really exciting work to work with these teams. Next slide, please. So how we approached the work was using a quality improvement type framework where we asked all of our demonstration programs to do a partner engagement plan. So look at the local partners that they were going to work with, everyone who's involved in lower limb preservation. So a current state assessment was done of a typical patient journey as it was when we first started the work. And then we asked teams to envision their desired state. Where did they want to go based on the lower limb preservation framework? And through that, teams were able to identify where there were gaps, where perhaps the local resources didn't meet the needs of that evidence-informed practice. And that's what led to change initiatives. And so these were identified and prioritized for the teams. And we also asked for an implementation plan, followed up by measurement and evaluation. So on just highlighting some of the key themes, I feel like this slide doesn't do the justice all the work that the teams have done. It really simplifies it. But this was a lot of work and time and effort and thought process went into, as I'm sure everyone on the call has been involved in some type of quality improvement initiatives. And it is a lot of time and effort to get that going. But we did find two key themes with our teams and the outcomes and the change initiatives implemented. And that was the increase in foot screening, and with that, the risk stratification and the pathways for patients to follow based on that risk stratification. Next slide, please. So here's an example, and again, this doesn't do justice the amount of work that teams have done, but there's our Windsor right up top, and they're going to go into some more details of the amazing work that they've done. But here's just a small subset of some other teams and the work that they have done as well. These were links. I'm sure we'll be sending follow-up slides. I don't know if the links will work, but I really encourage you to go to these OHT websites because they all have postings on their websites and resources to talk about the amazing work that they are doing. And so just in summary, we talked about the framework, we've talked about OHTs and how they're positioned to drive that integrated care. But we all know it's one thing to have a framework on paper, and it's a whole other thing entirely to bring it to life in a way that can truly improve patient care. And so that's where Windsor team has really led the way And they've turned those principles of integrated care into action, and with deep commitment and collaboration with their partners. So I'll pass it over to them now to share how they've made this work real on the ground. So thanks.
Thank you so much, Dr. Orr, for sharing that valuable perspective on integrated care and the broader provincial strategy. It's kind of great to see how these system level approaches are aligning with our work on the ground. At this time, I'll pass it back over to Christen, who will be walking us through more details on our Windsor Essex demonstration site and how it fits within the larger provincial framework.
Thank you, Harrison. Next slide, please. As Dr. Orr mentioned, Windsor Essex, where many of you are joining us from today, was selected as one of our provincial demonstration sites for the Core Health Lower Limb Preservation Integrated Clinical Pathway Project. And through our strategy at the Windsor Essex OHT level, we've been focusing on a few key goals. First, we aim to assess patients with diabetes and/or peripheral arterial disease, whether or not they already have lower limb wounds. We're also applying a health equity lens by risk stratifying patients from vulnerable populations, like clients from the homeless hub or those living in high-risk postal codes. Another priority is to divert the high-risk patients from the busy emergency departments and instead connect them with more timely, lower access assessments and treatment within the community. And finally, we've been working hard to equip healthcare providers with the tools, education, and support they need to deliver best practice care for lower limb conditions. Because early intervention starts with awareness and access. Next slide, please. Our strategy was designed with a clear focus on populations who are at greatest risk for amputation and often face most barriers to care. So we've been targeting individuals who have active lower leg wounds and those diagnosed with diabetes, PAD, and/or end-stage renal disease. We're also prioritizing those who are unattached to primary care, as well as those who are homeless or street involved, or live in high priority neighborhoods or are facing any other social barriers like lack of transportation or unstable housing. Here in Windsor Essex, we're also placing a special emphasis on supporting marginalized and homeless individuals who are disproportionately facing these lower limb amputations due to the compounding effects of the chronic disease, addictions, and any systemic inequities. So this work has been largely about meeting people where they are and ensuring that no one slips through the cracks because of circumstances that are beyond their control. Next slide, please. Thank you. Our lower limb wound prevention and treatment clinic was built to provide a comprehensive team-based approach to care, especially for individuals who are high risk, as mentioned, or underserved. At the clinic, we also offer lower limb assessments along with the prevention and treatment that is tailored for each patient's needs. We address issues like loss of sensation, foot deformities, pain, and other risk factors that contribute to wound development. Patients also have access to foot care, diabetic socks, and appropriate footwear, which can make a huge difference in prevention. And we also provide primary care support for related conditions, and if needed, offer referrals for diagnostics, lab work, ongoing wound care, and additional resources. What's just as important is the follow-up care that we provide, so tracking each patient's progress and adjusting their care as needed. And we work closely with each of the patient's circle of care, making sure that communication and coordination are in place so that no one, again, falls through those cracks. So the Lower Limb Wound Prevention and Treatment Clinic was launched on October 26, 2023, as part of a coordinated strategy to enhance access to lower limb care in the Windsor Essex region. And the clinic operates by appointment here at 2475 McDougall Street in Windsor, in collaboration with the Windsor Family Health Team and with our partners shown at the bottom of the referral form. It is also accessible via virtual consultation at various shelter health sites within Windsor's core, allowing for flexible access to our patients. And the intended goal is to provide patients with an appointment within 72 hours of referral and when clinically appropriate. On the slide, you'll also see, again, the image of the referral form that is used for the clinic. So when submitting, we do encourage providers to include the patient profile along with any relevant documentation such as investigations, consult notes, or clinical summaries to support the coordinated and informed care planning. As part of the demonstration, a weekly outreach walk-in clinic was established at H4, also known as the Homeless and Housing Health Hub, located at the former Water World in Windsor. While it was initially offered in person, it has now transitioned to a virtual consultation site through the Shelter Health Program, allowing us to maintain that continuity of care and in a more flexible format. This clinic continues to focus on marginalized populations, including individuals who are homeless, street involved, or facing significant barriers to traditional healthcare. Services include foot care education, walk-in access to the diabetic socks, shoes, foot orthotics for all people at all levels of risk. And care is delivered collaboratively by nurse practitioner, Harleen, who's with us tonight, and wound care nurses through the Windsor Family Health Team and the Mobile Medical Support Team. And this is all coordinated through the Windsor Essex OHT. Medications such as antibiotics can be prescribed when needed, and on-site pharmacotherapy is available for patients without health cards. We also help arrange free transportation and follow-up appointments and referred resources or services, helping to reduce those common access barriers that they often encounter. A key part of effective lower limb preservation is making sure we're identifying risk early before wounds develop. And all patients with diabetes do receive a routine foot assessment by a health practitioner and having a standardized approach, ensuring consistency and early intervention. So at the clinic, we also use the InLo 60-second diabetic foot screen, which is a validated tool that helps us both assess risk and guide clinical decision-making. We also use, this tool is also used by nurse practitioner Harleen, Sanghera, who's with us tonight again, and she will be walking us through these assessments and screening tools in detail later on in the session. And with that, I'll pass it back to Harrison, who will introduce our next speaker. Thank you.